Hello, I'm Dr. Janet Pope, a professor of medicine at Western University in London, Ontario, Canada. And thank you for inviting me to this meeting. It's the second year in a row to come here, virtually, of course. So I've been asked to speak about where do JAK inhibitors belong in RA treatment? And that's a very difficult task. These are my disclosures. So we know RA has a high burden of disease. You can see the hands in the upper corner with severe damage and rheumatoid nodules. But when we're treating a patient, we're looking at cardiovascular risk, socioeconomic issues, work productivity, also affordability of drugs, cancer, infection, osteoporosis, and psychological issues such as depression. So there's a lot we think about when we're treating our patient because the comorbidities and burden could be high in our patients. So how do we choose the right treatment for the right patient at the right time? Access is always important. Without that, we don't have treatment. So the physician's experience, there are regional and country differences, personal experiences differences. Patient considerations would be age, comorbidities, reluctance to change treatment, patient preference, and as I said, access, and then evidence to support the treatment, recent research, clinical guidelines, RCTs, meta-analyses, etc. So where do JAK inhibitors fit in for RA treatment? We will look at guidelines and recommendations, but you would also be wondering about access and cost. There's a difference in innovator drug costs, and biosimilars are less expensive. Benefits of TNF, so monotherapy versus combination therapy, head-to-head trials, safety, patient preference, and I also look at the durability of response. I'm treating for the long term, not for the short term in RA. So the EULAR guidelines are being updated, but the 2019 say that once you have not responded fully to methotrexate alone or with glucocorticoids or in combination with CS-DMARDs, to think in poor prognostic patients who have active RA, to think of going to an advanced therapy. And at this point in time, it would either be a TNF inhibitor, other bio-DMARDs, or JAK inhibitors. And the only one not on equal footing in some guidelines would be rituximab, where in some countries it's only after a TNF inhibitor, but certainly has data after methotrexate inadequate response as well. Then phase 3 is usually switching to another advanced therapy if what you're doing isn't working or isn't safe. And when you switch, often going out of class instead of within class would be what I would think as a recommendation. So the American College of Rheumatology guidelines are similar. You're going to start in poor prognostic patients with methotrexate. And if they are not doing well enough and have positive ACPA, lots of joint swelling, high CRP, or erosions, you're going to move on to an advanced therapy. And don't discontinue the effective drugs that work. Keep them going. We also know that early intervention, there's a window of opportunity in all our diseases, and best studied in RA, where treating early, you'll reduce joint damage. And in our early arthritis cohort in Canada, the CATCH cohort, we looked at patients achieving remission in early RA, so they should be the easiest to get remission. So the good news is 55% in 1 year achieved remission as a very tight definition, and SDI less than or equal to 3.3. The bad news is over time, only half of them stayed in sustained remission over the next 2 years. So we really need better products and better ways of treating our patients. However, those who achieve sustained remission have less pain. Patients who get early improved function as measured by the Health Assessment Questionnaire, or HAQ, Disability Index, in our study have less mortality or the follow-up in early RA. So we need to achieve remission, we need to get sustained remission, and those are difficult, and then we need to know what to do. So JAK inhibitors have been approved in rheumatology, some have been studied in gastroenterology, and also in dermatology. And the real debate comes in on the relative safety of JAK inhibitors compared to TNF inhibitors. So everyone's familiar with the oral surveillance study, which was looking at patients over the age of 50 with one or more cardiovascular risk factors who had active RA, failing methotrexate, and treatment was added to methotrexate of tofacitinib 5 milligrams twice a day, or 10 milligrams twice a day, or a TNF inhibitor. The TNF inhibitor was etanercept in most of the world, but adalimumab in North America. So these were high-risk patients. And what was found was, first of all, there were no statistical differences between cardiovascular events, or MACE, major adjudicated cardiovascular events. However, there was numerically higher events on tofacitinib, and the confidence interval around the assumption showed that the confidence interval went from slightly protective to more harmful on tofacitinib, and beyond the adjudicated decided confidence interval, there were more events beyond that rate. So what does this mean? On MACE, what you can look at is the number needed to harm over a 5-year period treating with a JAK inhibitor as opposed to a TNF inhibitor over 5 years. On tofacitinib, 5 milligrams twice a day would be over 100. So in other words, you have to treat 100 more patients over 5 years in the high risk group to have one event, or 400 patients over a year to have one event. Malignancy was also numerically increased and nearly statistically on JAK inhibitors compared to the TNF inhibitors. And you can see the malignancy rates where the confidence intervals on the bottom panel are more or less overlapping. And so over 1 year, high-risk patients to have one more malignancy of any sort treated with a TNF inhibitor in RA would be treating 275 more patients compared to a TNF inhibitor. So numerically higher, large numbers needed of patients to treat to harm one, but these are the data. And just reminding you here, the cardiovascular risk population had 2/3 were ever or present smokers, higher than other RCTs. Hypertension was in 2/3, about double that of other RCTs that are traditionally done in RA patients. So these indeed were high-risk patients, more hyperlipidemia, et cetera. So if we look at the older trial of etanercept versus tocilizumab, looking at cardiovascular events, the INTRACT trial showed the event rate for tocilizumab was 1.82 per 100 patient years, and etanercept, it was 1.7 per 100 patient years. And that is actually both higher than the event rates looking at the contemporary trial, the oral surveillance. The oral surveillance event rate was actually lower than in INTRACT for both TNF and for a JAK inhibitor. So this is the context that we can compare things. So what about looking at other trials? So there's a meta-analysis showing no increased cardiovascular events and no VTE increases in JAK inhibitors, looking at 12,000 patients in 26 RCTs. What about reaching remission, though, and what happens to cardiovascular events? So certainly looking at bio-DMARDs, there are reaching remission with bio-DMARDs, there are less cardiovascular events than even reaching remission with CS-DMARDs. So there's something about advanced therapies such as TNF inhibitors that seem to decrease cardiovascular events, possibly above the remission that is found. We also know the STAR-RA was a large administrative data just published looking at 102,000 RA patients, of whom almost 13,000 or nearly 13% of patients were on tofacitinib. And what they found was the event rate of cardiovascular events was the same of tofacitinib versus other comparison advanced therapies. If you looked in the high risk group, it was advanced therapies versus tofacitinib and those with high cardiovascular risk. The event rate was 1.24, which was similar to oral surveillance where it was 1.33. And it was not statistically significant despite these large numbers, but the event rate was about the same as oral surveillance. So again, a hint that this is safe, or if you're very cautious, a hint that possibly TNF inhibitors would be safer in the high-risk group, but not statistically different. We also know here, looking again at malignancies, the number needed to harm, you have to treat nearly 275 patients for 1 year, and high-risk patients to have one more cancer. We also know TNF inhibitors are not associated with an increased risk of cancer compared to placebo, except for, we do know all advanced therapies have more skin cancers. There's another systematic review here looking at cancers, again, was showing no increased cancers, and looking at serious infections were numerically and statistically increased in the patients on TNF inhibitors compared to CS-DMARDs, and cardiovascular events were actually reduced. Also, cancer recurrence. There's a lot of data on TNF inhibitors not increasing cancer recurrence compared to other options, and we don't have those data yet on JAK inhibitors. So here, this is looking at recurrence of cancer on TNF inhibitors, another systematic review of 9 studies, not randomized, of course, and showing no difference on TNF inhibitor use versus not using an advanced therapy. If we look here, malignancies, this is the rate, adjusted and unadjusted, of tofacitinib versus bio-DMARDs, and excluding skin cancers, no difference. If we look here at malignancies in a systematic review of JAK inhibitor RCTs, methotrexate inadequate responders, no statistical increased risk of cancers. But as I said, skin cancers are increased in advanced therapies compared to placebo, but compared to doing other treatments, the rates might be similar. It's difficult to say. We also know serious infections were increased in the oral surveillance. And if you look at those over 65, that's where the difference was between JAK inhibitors, a rate of 4.4 per 100 patient years versus 3.7 per 100 patient years with the TNF inhibitor in those over the age of 65. Oral surveillance, otherwise serious infections were about the same in the younger age group. We know that all JAK inhibitors increase zoster compared to methotrexate and compared to TNF inhibitors. For TB reactivation and latent TB infection, all advanced therapies will need TB screening with the exception of rituximab. And whether the rates are higher in some TNF inhibitors compared to JAK inhibitors is difficult to say, but all your patients going on a JAK inhibitor or a TNF inhibitor in RA should be screened for TB and treated with LTBI treatment where needed. If we look here at VTEs, TNF inhibitors versus CS-DMARDs have actually less VTEs or protective in this systematic review, but VTEs have been associated with JAK inhibitors such as baricitinib at 4 milligrams a day during the RCTs, but not in long-term extension, not at 2 milligrams a day, and not really in the real-world studies. However, VTEs were increased on tofacitinib in oral surveillance study compared to TNF inhibitors. This is another real-world study looking at tofacitinib versus TNF inhibitors in 50,000 RA patients, and both had low rates of VTE, and it was numerically a little bit higher on tofacitinib, but really not different clinically, and certainly not different statistically. We also know from the US registry of patients that tofacitinib had no difference versus bio-DMARDs in VTE, both looking at DVTs and pulmonary emboli. So what has the American College of Rheumatology told us? So they updated their guidance on Jan 28th, so very recently. And what they did was they looked at the oral surveillance study, which I'm showing you again here, showing more MACE, more PE, more DVT, more VTE in total, more malignancy, including non-melanoma skin cancer, and more deaths from any cause. So that's what we know. And again, most of these findings are not statistically significant. The study was not powered for statistical significance. It was powered for a hazard, a confidence interval to be within a range between TOFA for MACE and between TOFA and TNF as well for malignancy. So what they said was the FDA has had a ruling that in RA and our other rheumatic diseases that you should consider a JAK inhibitor only after a TNF inhibitor. That is not the case in Canada, and I'm not sure what your warnings are in Pakistan currently. However, the ACR, American College of Rheumatology, recommended shared decision-making and that we should consider the best options, including TNF naive patients, considering a JAK at any option where appropriate. So RCTs of JAK inhibitors, I've talked a lot about safety. What about efficacy? And what about some special areas of interest in safety? So we know that in the oral standard study, it was not a head-to-head of tofacitinib compared to adalimumab and methotrexate inadequate responders. We know that the data were about the same on tofa and adalimumab. We also know that looking at oral strategy, comparing methotrexate inadequate responders, then randomized to tofacitinib 5 milligrams twice a day and stopping methotrexate, or adding to methotrexate either adalimumab or the tofacitinib 5 milligrams twice a day. And again, it looks numerically that you do about the same adding tofa or adding adalimumab, but not as good if you just stop methotrexate at the beginning. And baricitinib added to methotrexate and methotrexate inadequate responders, 4 milligrams of baricitinib was statistically and numerically better than adalimumab. Likewise, upadacitinib, 15 milligrams a day, and methotrexate inadequate responders added to methotrexate was statistically and numerically better than adalimumab being added. So we also know that deep remission, such as DOS remission of less than 2.6 or a CDI remission, that following these patients from the upadacitinib trial, they are still doing better on the select compare trial if they're randomized to upadacitinib than to adalimumab. And this is looking at your sustained remission over time. And 1/3 of patients will get into a DAS less than 2.6, and 1/4 of patients, or 20% of patients, will on adalimumab. So 1/5 or 1/4 of patients. We also know VTEs and all the RCTs of upadacitinib were not increased. We know that MACE was not increased in baricitinib, nor was DVTs over 6 years of follow-up, just the trials in 4 milligrams versus placebo in the RCT phase. We also know that serious infections in older patients from the German registry in rheumatoid arthritis were not different between all the products they looked at in this real-world study, a database or registry, but it was higher real-world infections in elderly patients compared to younger patients, but not different between the products of TNF, JAK, IL-6, etc. Herpes zoster is always increased in JAK inhibitors and RA compared to adalimumab or methotrexate. And again, you're seeing it's increased here in upadacitinib in a dose-dependent fashion. We only use the 15 milligrams. And this is looking at baricitinib over time. Serious infection rate is stable over time, and herpes zoster is stable, but increased compared to something like adalimumab. Malignancies were not found in the RCT databases of the JAK inhibitors in RA. They weren't found to be elevated compared to the placebo or methotrexate or TNF. However, obviously the studies weren't powered to look at malignancies, and the RCT part of the trials only goes on for at most a year for most studies. And then looking here, malignancies in baricitinib were stable over time. What about monotherapy? Interestingly, unlike TNF inhibitors, monotherapy in JAK inhibitors seems to be as good as combination therapy RCTs. And that is true for IL-6 inhibitors as well compared to TNF inhibitors. So monotherapy, the oral solo, you can see the responses of active treatment on tofacitinib 5 milligrams twice a day at 3 months are about the same as oral sync, which was added in BioDMARD IR patients, and also oral standard where methotrexate was on board and you added tofacitinib. So same with oral scan and oral step. So it looks like monotherapy results are not blunted, at least for ACR response and tofacitinib. What about upadacitinib? You can see as well, monotherapy at 3 months and methotrexate inadequate responders has the very same data as select early, select compare, select next, and select beyond. And in fact, better than if you were a TNF inadequate responder, of course, because they're a little bit more difficult to treat. What about if you discontinue methotrexate when you've achieved a good response with, say, tofacitinib? This large trial looked at long-acting tofacitinib, so 11 milligrams a day is equivalent to 5 milligrams twice a day of tofacitinib. So everyone gets treatment. They're methotrexate inadequate responders. They maintain methotrexate. Then if you get a deep response, which most patients did at week 24, you're randomized to stop methotrexate, which is the blue, staying on tofacitinib monotherapy, or continue with tofacitinib, which is the orange, and you can see the results are the same. So once a patient's doing well, at least in RCT, stopping methotrexate is about the same as continuing it if you look for the next 6 months. We also know, as I mentioned, that TNF inhibitors are always more effective when used with methotrexate when you look in trials. With an individual, that's not always the case, but at the group level, it's always better on combo therapy than monotherapy for TNF inhibitors in rheumatoid arthritis. We also know, though, when you're trying to choose what to use, is that we have 20 years of experience with TNF inhibitors. 2013 was the first release of a JAK inhibitor in RA, and that was Switzerland and the US. And in Canada, we got it in 2014. So we also have a lot of experience now with some JAK inhibitors in the real world experience in rheumatoid arthritis. Looking at retention, because when I'm making a decision on a patient of what to use as an advanced therapy, I'd like the drug to work for a long time. Many studies have shown the retention of JAK inhibitors is better than TNF inhibitors, and often the retention is a dose response of JAK inhibitors have the best retention, then other BioDMARDs, not TNF, then TNF inhibitors the lowest retention. And so this is also looking at monotherapy or combination therapy. This is looking at the Swedish registry. And what we're finding here is that TOFA combination had the best retention in RA in a real world registry by Fink et al. And mono and combo not too different. Other mechanisms of actions that were BioDMARDs, not TNF, the next best, again, mono and combo, very similar. TNF, the least retention, and monotherapy is the dotted lines. Monotherapy, TNF, the very worst retention. So that might influence what you're going to choose for your patients. We have also looked at 2 sites in Canada on retention, and we have looked at JAK inhibitor as first line or any line advanced therapy, TNF inhibitor as first line or any line advanced therapy, and we adjusted for age, gender, disease duration, and in this case, line of therapy. And you can see the retention of JAK inhibitors is better, and it starts separating by about 1.5 years. These are up to 80 months, and we only looked at new prescriptions from 2014 on for the advanced advanced therapies, because that's when our first JAK came to market in Canada. And even a wider separation of durability of response if you look over 80 months on those on JAK inhibitors as first-line advanced therapy compared to TNF inhibitors. So our data are in line with other findings. Not all registries, though, find a difference, but many do, and most do. The reasons for discontinuation are different. So no difference in risk of discontinuation due to adverse events in our study of over 500 treatment periods and over 330 patients. But their JAKs were less likely to be discontinued due to loss of efficacy. So when is a JAK inhibitor not appropriate? In my opinion, active cancer, severe recurrent infections or frequent hospitalizations for serious infections, active or recurrent shingles despite vaccination, past DVT or high-risk DVT if they're not on anticoagulation. Of course, I'm not going to anticoagulate, though, a person who's never had a DVT but has risk factors, because the risk of anticoagulation with bleeds would be higher than any perceived benefit. Pregnancy, breastfeeding, or contemplating pregnancy, we want to use a TNF inhibitor over a JAK. Severe organ failure, such as dialysis, you have to look at the safety of the JAKs and really lower your dose or not use it. Decompensated cirrhosis, where the safety has not been studied, and TNF inhibitors are fine in cirrhosis patients. Patients on potent other immune suppressives, such as transplant patients, because there's some drug interactions and more serious infections. And some drugs will alter the metabolism of JAK inhibitors, such as oral antifungal agents. And so you might hold the JAK or just look at the warnings that you can find if you need to treat long-term, say with ketoconazole or fluconazole. So key points: strengths of TNF, no contraindication of TNF for NASH or liver damage. JAKs, you have to dose adjust, and severe liver damage, JAKs have not been studied in RCTs. No contraindications for liver damage as well prior to cirrhosis for TNF inhibitors. And you can use TNF inhibitors in patients with Hep C. Now we would actually cure Hep C and then use whatever treatment we feel is just and right. We also have to monitor more on JAK inhibitors and a TNF. So your complete blood count, the differential of the white count, the hemoglobin, the platelet count, and liver enzymes. Whereas on a TNF inhibitor, you don't really need to do that monitoring. However, if the patients are on methotrexate, the monitoring would be the same whether you're on a JAK or a TNF inhibitor. What about patient preferences? Many patients prefer oral treatment. They don't have to worry about refrigeration or injections. But if you're choosing a TNF inhibitor, they often want less frequent injections, but there is a lot of differences in patient preference when you're looking at TNF inhibitors. However, oral is always preferred first. So we have talked about safety. We've talked about benefit. We've talked about monotherapy, where JAKs seem to be better in retention and better in efficacy than TNF and monotherapy. We have talked about access, and we've talked about some special cases like cirrhosis or pregnancy. So can I answer the question I've been asked? I think there is no right answer. I think it's important to note that RA patients have several options after they have not fully responded to conventional synthetic DMARDs or broken through over time. And the order of advanced therapies and which class to choose will depend in your patients on access, comorbidities, and patient and physician preference. So after all that, I hope you've learned something, but we really can't answer the question of what to use in every single patient. So with this, I thank you, and I hope you enjoy your meeting.